people have turned up, so I think we'll start. So welcome everyone, and thank you so much for coming. So my name's Jessica Michael, and I'm a PhD student at the Epworth Centre for Innovation in Mental Health, or ECIMH, as you'll hear a lot throughout today. So today we're going to present the second webinar in a series of monthly webinars that we're holding. So I'm here today with my co-host, Dr. Oscar Murphy. He's a postdoctoral research fellow at ECIMH, and he runs several trials investigating the effects of brain stimulation in treating psychiatric conditions such as depression, OCD, and many more. So just a little bit about how today's going to run. As Oscar has said, Freya is going to present for about approximately 35 minutes, and then we'll have question time afterwards. But while she's presenting, feel free, you might see there's a Q&A button at the bottom. Just chuck your questions in there and we'll get around to them at question time. So without further ado, I present Freya Stockman. So Freya Stockman is a research officer here at ECIMH, and she has played a huge part in helping to put together this monthly webinar. And she has extensive experience in brain stimulation techniques, and she is here today to present a practical guide to brain stimulation. So welcome, Freya.
Thanks, Jess. I'll just share my screen with everyone. Okay, so an overview of the presentation that I'm going to be presenting today, why brain stimulation research is beneficial, a detailed look at the different types of brain stimulation techniques that are available out there, as well as demonstration videos giving you a bit more of an understanding of how they actually work and how we actually measure brain activity and the effects of brain stimulation using EEG. But first, a bit about me. So I completed my bachelor degree in psychological science in 2016. I then went on to complete a graduate diploma of psychology in 2017, and my thesis examined the relationship between mirror neuron activity and empathy using transcranial magnetic stimulation, as well as assessing the relevance of intelligence. So my research was supervised by Professor Peter Endicott, who also gave me the opportunity to contribute to an international book collaboration looking at the different types of techniques that can be used to affect ASD symptoms. So that was an awesome opportunity. I then worked over summer in 2017 as a research assistant in the Cognitive Neuroscience Unit at Deakin under Peter Endicott. And that led me to my role as a research assistant and study coordinator at MAPRC in 2018, the following year. So I worked at a range of trials looking at various forms of brain stimulation techniques, which I'll cover later in the presentation. But for now, the abbreviations are TBS for the treatment of fibromyalgia, so that is to do with chronic somatosensory pain symptoms. TACS for the treatment of mild cognitive impairments, so a decline in memory that is outside of normal aging. And I also helped to develop portable at-home treatment kits, which we now use across several of the studies in the centre so that people can access treatment at home. And my current role as a research officer at ECIMH, I coordinate the MCI study still, and I also work across a range of Alzheimer's related studies using various forms of stimulation techniques. So why brain stimulation research is beneficial? Well, we can use brain stimulation to increase and decrease brain activity, which can lead to changes in mood, behavior, and thinking. So by investigating the effects of brain stimulation on the brain, we can do a range of things. We can understand how the brain works, what areas of the brain contribute to what processes or behaviors. We can understand how symptoms develop in certain disorders, and that can lead us to developing treatments to address those symptoms. So all of those things can occur through brain stimulation research, and it's our primary focus at ECIMH. So this research model has also helped in the securement of medical listing for TMS as a treatment for depression. So this process has taken over 10 years, thanks to Professor Paul Fitzgerald, who heads the centre at ECIMH. And essentially what it means to be listed on Medicare means that instead of having to pay thousands of dollars privately or needing private health insurance to access this treatment, it will be subsidised by the government and more affordable to the general public. And essentially being listed on Medicare essentially means that there is enough proof or evidence to show that this treatment has a significant positive impact that the government is going to back it and invest money into it for the benefit of health in Australia. So brain stimulation can help us to identify which brain regions contribute to certain functions. So previously, the only way to understand how this occurred or what brain regions were implicated in what behaviors, symptoms, was to wait for somebody to have a brain injury, which is not super convenient or a great situation to put yourself in as a researcher or the patient. But now we can actually use brain stimulation to create what we call virtual lesions in various parts of the brain, which temporarily disrupt the functioning of brain networks so that we can safely observe the effects on functioning and determine the role of each region. So now we've gained a broader understanding of how the frontal lobe contributes to executive functioning, attention, and processing of information. We have seen that learning and memory is also associated with various parts of the brain, like the hippocampus. We know that language and other various, we've gained a broader understanding of all these different functions through brain stimulation. So it has been extremely beneficial in understanding the brain. And the reason we can modulate brain activity is because the brain operates similar to a computer. It's an electrical system, an electrical and chemical system. So brain stimulation, both electrical and magnetic, can target these electrical currents to increase or decrease the activity. So I'm now going to show you a short 1-minute video that gives a really good insight into what I mean by virtual lesions and how we can assess disrupted networks. So I hope you enjoy it.
If we start at the back of the brain, we've switched off my visual cortex, so made me unable to see things. If we move a little bit forward in the brain, we've interfered with people's ability and my ability to see faces. A little bit further forward, we've interfered with the ability to perform actions. Start moving your finger. Quite odd. It's not your finger anymore. It's not my finger anymore. We've interfered with the ability to compute with numbers. 6, 7, 8. Okay. Ooh, yeah. We've interfered with the ability to speak. London Bridge, London Bridge, London Bridge is falling down. You think of something you can do, and we've basically interfered with it with this machine. 2, 3, 4, 5, 6, 7, 8. So 9. What's the problem? I don't know.
Okay, so also on top of understanding how the brain works through the use of virtual lesions and developing an understanding of symptoms, we can understand how to develop treatments. Now, there are pharmaceutical treatments available for a lot of mental illnesses or medical conditions. However, there are limitations when it comes to pharmaceutical medication. For one, the development time is very long. So it takes 11 to 18 years for a form of medication to make it to the public, to be accessible and available to the public for treatment. Whereas with medical devices such as brain stimulation, this can occur in a shorter time frame, between 4.5 and 10.5 years. So there's a dramatic difference in the length of time necessary to get a treatment to the public for accessibility. And another good example is that 30% of people with depression don't actually respond to medication, and that's a large proportion of people. Now, I'm using depression as a specific example, and there probably are other examples, but yes, 30% of people with depression will not respond to medication. And on top of this, medication indirectly targets brain regions. First, you have to ingest it. It has to be processed through your digestive system before it makes it to the various regions of the brain that it's targeting. And in that process, it can actually lead to adverse side effects elsewhere in the body, which can be unpleasant or really impact your health in other ways. Whereas brain stimulation is a way for us to directly target brain regions and kind of skip that entire process. There's less side effects, and 50% of people who are treatment resistant to medication with depression will respond to TMS. So it also acts as a bridge between medication and more intensive stimulation treatments like ECT and DBS. It's sort of the middle ground to try and help people before they may explore more intensive alternatives. So what types of brain stimulation techniques exist and how do they exactly work? So I'm about to present information about various brain stimulation techniques, but this is literally only the tip of the iceberg. So there are many that exist out there, many hybrids of various techniques. So I'm just going to present about the ones that we have the most experience with at ECIMH. So non-invasive brain stimulation is made up of two different types, as magnetic and electrical. So when it comes to magnetic stimulation, I'm going to be talking about TMS, transcranial magnetic stimulation, and TBS, theta burst stimulation. And with electrical, I'll be explaining how transcranial alternating current stimulation works. So TMS uses a magnetic field that causes brain cells in a specific region of the brain to generate electrical currents. It can increase and decrease brain activity, leading to changes in mood, behavior, and thinking, and has been used by our researchers for over 20 years to treat depression and other psychiatric illnesses. It is considered extremely safe, and we are also currently investigating whether it has benefits for improving cognition. And I guess the reason that we would want to investigate brain stimulation as a treatment is because neuroimaging, so things like fMRI, have shown us that certain parts of the brain are underactive in conditions like depression, such as the DLPFC. And so we can target the DLPFC and increase brain activity using brain stimulation. So that is a reason why you might want to increase brain activity or decrease it, which brain stimulation allows us to do. So part of conducting brain stimulation is personalizing the intensity of the stimulation for each individual. And this is known as obtaining the resting motor threshold, or RMT. So RMT is a minimum intensity required to produce a motor evoked response while at rest. So it's an involuntary muscle movement that is stimulated or activated using stimulation to the brain. So we target a part of the brain called the primary motor cortex that is specifically, I guess, in control or related to hand movement. So if we target the left primary motor cortex, we can impact the right hand. And if we target the right primary motor cortex strip, we can target the left hand. So the reason that we actually we apply brain stimulation to the primary motor cortex is because it's the only brain region that shows a visible reaction to brain stimulation. So the twitch in the hand is a visible way for us to ascertain as to whether we have reached someone's resting motor threshold. And we start as low as 30% and slowly work our way up by 5% until we get that twitch in the right hand, which is also measured using electromyography, or EMG, which is that little squiggly line in that talking box coming from the hand there. So that's an example of a response to TMS. And so again, we use this to personalize treatment intensity. We also use it to amplify brain activity so we can get a better recording if we're targeting specific regions of the brain and we want to get a clearer reading on it. So I'm now going to show you a demonstration video that shows the response to TMS and the twitch in the hand, so you can see how it works in real time.
If a new optimal spot is located, that is, another spot at which a larger response is elicited, then mark the new spot and repeat testing around the lateral, medial and sagittal grid. Once you've determined the optimal spot, apply a total of 5 pulses with each spaced 5 seconds apart. If at least 3 responses are elicited over 5 pulses, reduce the intensity by 1%. Repeat this process until less than 3 responses are elicited over 5 pulses. The resting motor threshold is 1% higher than the intensity at which less than 3 responses are observed for every 5 pulses. For this person, the resting motor threshold is 38%.
Okay, so that was an example of resting motor threshold and the twitch in the hand. So it's pretty cool to see that we can actually immediately affect behavior by applying brain stimulation to the primary motor cortex. So another form of magnetic stimulation, a part of the TMS family, is theta burst stimulation. So it is a form of TMS where magnetic pulses are applied in short, rapid bursts, similar to natural activity that occurs in brain cells. So we can promote increased lasting changes in local brain activity as well as surrounding connected regions. And the benefit of using TBS is it is a much shorter time frame to apply treatment than TMS. And this is because the short, rapid bursts of pulses can be conducted all within 3 minutes instead of 30 minutes, because TMS is applied in a shorter, more individual pulses. So an example of experimental outcomes using TBS as part of a study that we did for looking at fibromyalgia, so chronic somatosensory pain, we used TBS to stimulate a brain region called the dorsolateral prefrontal cortex, thought to be underactive in fibromyalgia, which is involved in the experience of pain. So what we were told by some patients was that they saw a dramatic improvement in pain reduction and daily life, and also an improvement in mood. However, within clinical trials, there are some people who don't respond to the treatment. So we're still trying to explore why that might be and whether the treatment is effective for most people. So now I'm going to talk to you about transcranial alternating current stimulation, which is a form of electrical brain stimulation. So what it does is it generates gentle electrical currents that can change patterns of electrical brain cell signals between 2 brain regions. So how it is done is by using 2 electrodes that are placed on the scalp, and the sensation typically feels like tingling or itching. And what we found is that we have seen an improvement in working memory, attention, and learning abilities after somebody's received TACS for a prolonged period of time. So it's extremely gentle and extremely safe. And the way that TACS can improve cognition, even though it is so gentle, is because people receive it on a daily basis. So that ongoing treatment is what makes the lasting changes. So the way in which it actually works is it works by entraining brain activity. And what I mean by entraining is it uses a varied rhythm that is similar to how brain activity typically functions. So it mimics it, but what it does is in mimicking the varied rhythm, it then slowly increases or decreases to then encourage the brainwaves to fall into synchronization with it. So if you see this diagram here, you'll see the blue squiggly lines going up and down. That's natural brain activity. So that's a natural rhythm that I was talking about. And then this red line that is very defined and is increasing quite rapidly, that is when we are applying TACS. So it's helping the brainwave to fall into synchronization with it. And over a prolonged period of time, hopefully what we'll see is prolonged changes in the way that the brainwaves function. So here in this second part of the diagram, increasing entrainment or increasing the frequency once entrained, it's a lot more rapid. And then we can also slow it down for these more slow and deeper brainwaves. So different frequencies occur naturally in the brain, such as gamma, beta, alpha, theta, and delta. So all TACS is doing is either strengthening or weakening these types of frequencies in the brain. So they naturally occur. All TACS is doing is mimicking it and then either strengthening or weakening to get desired outcomes. So we actually measure these form of brain activity using what we call EEG or electroencephalography. And so the aim is to measure changes in brain activity following treatments, and we compare that to a baseline, what we call a baseline reading. So we record their brain activity before treatment, and then we compare it to their brain activity after treatment to see whether we have actually had a desired outcome or change brain activity in the way that we thought we were going to with the stimulation. And then we look to see whether there's a relationship with the changes in brain activity with changes in behavioral or cognitive data. So have they improved their memory and thinking abilities used through the tasks that we've been conducting with them? Have their responses to questionnaires changed? We have a look at all of those things to assess if the treatment has actually had a desirable outcome and has worked. So how EEG actually works is that we record brain activity using a cap that has approximately 64 electrodes attached to it. So lots and lots of wires coming out of this one cap. And essentially what it does is it acts as a bridge between your brain and an amplifier so that we can record those electrical currents happening underneath the skull. And then that goes into a program on the computer, which then sort of allows us to visualize these little squiggly lines, which is the brain waves in action, and they're naturally occurring. So we can compare the baseline to the post-assessment to see if we have increased gamma frequency or increased delta frequency within the brain waves. Okay, so I'm now going to show you some live EEG recordings of TACS entrainment in action. So these are live recordings of somebody wearing an EEG cap, just like I was explaining, and they're also wearing electrodes that are going to be applying different forms of TACS waves. I'm first going to show you delta waves. So this is at 2 Hertz. And they're associated with deep sleep and motivational processes. So watching the screen, you can't really see all too much now, but now you'll start to see these big, deep waves occurring. And so those are your brain waves functioning at 2 Hertz. And this is directly in response to TACS being turned on and applied to the scalp. I'm now going to show you alpha waves, which are associated with resting state, mental alertness, coordination, and learning. And you'll see that they look vastly different to the delta waves. So they're really fast, rapid, there's a fast, rapid rhythm to them, and they're creating these very intricate sort of geometric patterns. So this is at 10 Hertz. And I'm now going to show you gamma waves. So this is at 40 Hertz, and we apply this form of stimulation in two of our clinical trials looking at MCI and Alzheimer's disease. So gamma waves are associated with attention, focus, organizing thoughts, organizing thoughts, memory, and processing information. So you can see here that all 3 of them look incredibly different, and that is because they're functioning at a different hertz. Okay, so the future is officially here. Brain stimulation has come a very long way, and part of its evolution is we've now developed purpose-built portable devices that can deliver remotely supervised brain stimulation in the comfort of your own home. So this is going to revolutionize treatment. It's going to make it more accessible to people no matter where you live in Australia or the world potentially. So the stimulation frequency can also be modulated depending on what outcomes you want to achieve within the brain and behavior or cognition. So essentially the possibilities are limitless when it comes to electrical stimulation using devices. And if you remember me talking about device development in comparison to pharmaceutical development, the possibility of us creating and developing treatments is going to be fast-tracked compared, and so we'll hopefully be able to deliver treatments to people far sooner than if it was pharmaceutical-based. So, for example, at ECIMH, we use gamma TACS to treat memory problems in Alzheimer's disease and MCI. So both conditions are characterized by varying severity of memory impairment that is greater than normal age-related changes. So the premise of why we're using gamma frequency with TACS is because changes in gamma frequency activity may be contributing to cognitive changes observed in Alzheimer's and MCI. So by increasing and applying gamma TACS, we can hopefully restore this gamma activity, and this may lead to improvements in thinking, memory, and general connectivity in the brain when it comes to processing information and communicating between brain regions. And hopefully this may then prevent further decline in cognition for people who may be at risk of developing these conditions. So we hypothesize based on prior research that it will improve memory and thinking and strengthen brain connectivity. So I'm now going to talk to you about invasive brain stimulation. We have conducted studies using both deep brain stimulation, and we currently have a study that is has just been approved for ECT as well. So they're both very different to each other, but they both have their benefits for mental health and medical conditions. So deep brain stimulation, or DBS, is how does it work? So it's a small device that is surgically implanted in the chest that can deliver electrical stimulation to targeted areas of the brain using long surgically implanted internal electrode wires. So the stimulation has to be altered to suit individual needs. Some people will respond differently. It's a lengthy application process. So typically it will take many years before somebody will actually get approved to have the surgery and go through with it. So this includes medical evaluations, neuroimaging, taking scans of the brain so that we can then plan or target map which part of the brain is going to be targeted during surgery. It also involves electrode and device placement through surgery and programming the device for many, many months afterwards. So this form of stimulation is used to treat severe clinical depression as well as muscle tremors that are debilitating, such as those seen in Parkinson's disease. These are only two examples. I'm sure that there's other examples out there, but I'm just going to give you these two for now for our presentation. So how does DBS work? So I'm going to play this short video that really simply outlines exactly how it works. And I hope you find it really interesting.
People suffering from ailments like tremors and Parkinson's disease rely on deep brain stimulation as a treatment option. And now researchers are exploring whether this same method can be used to treat everything from depression to disabilities caused by strokes. Deep brain stimulation, or DBS, is designed to use electrical currents to target abnormal brain activity. The method triggers blood flow and a series of chemical reactions that leads to the release of neurotransmitters. Together, these actions help correct malfunctioning connections in the brain. This is how DBS works. A neurologist and other specialists use MRI and CT scans of the patient to map out and hone in on the location of the brain that will be targeted. Doctors then surgically implant electrodes on the targeted areas of a patient's brain using a thin probe called a lead. A wire attached to the lead runs through the head, neck, and shoulder under the skin to the chest area, where it attaches to a battery-charged pulse generator that initiates electrical impulses. Then doctors turn on the lead, sending an electrical current to the brain. The patient, now awake, may be asked to move an arm, for example, so doctors can ensure that electrodes are precisely placed. A few weeks after the surgery, the patient visits a neurology specialist who programs how strong of a pulse the device delivers, how long it lasts, and how many times per second the electrical pulses are delivered. Once the DBS device is programmed, it delivers continuous electrical stimulation day in and day out. Doctors tweak the voltage and other settings depending on individual patient profiles and what DBS is used to treat.
So I'm now going to show you a different video, only a small snippet of the video that I think is super relevant and interesting. So this woman is suffering from Parkinson's disease, and she's actually on the surgical table undergoing brain surgery while she's awake. And essentially what they're doing is testing out whether the how the DBS affects her brain while she's awake. Yes, I hope you enjoyed this video.
I was in college. I went to Michigan State University up in Lansing, Michigan. And it was my freshman year. And I went up on a Thursday night to have dinner, and I couldn't get the fork to my mouth.
What Marilyn Daner didn't know at the time was that she had a condition called essential tremor disorder. For more than 40 years, she's lived with the tremors. Recently, they've been getting worse. A neurologist referred Marilyn to the St. Louis University Movement Disorders Clinic to be evaluated for deep brain stimulation surgery. All surgery candidates are videotaped.
Okay.
So I'm just going to move it along.
And I'll open my hand.
Dr. Chand listens closely to the brain waves. The rhythmic, pulsing sound tells them they are close to the target.
I'd be willing to place a stimulating electrode at this point and see what we get.
The anticipation builds in the OR as doctors place the stimulating electrode and slowly turn on the current to begin testing.
So we see some benefit already. Tremor is stopping. Feel the tremor stop now? Very good, very good.
The patient is awake to measure her response as they continue increasing levels of current. Her response is stunning.
Hold your right hand up for me. Open your fingers. It's pretty good.
So DBS can be used to address conditions like Parkinson's. Like you just saw, her tremors immediately stopped once the DBS machine was turned on. And this form of treatment can also be applied for conditions like depression. So people who have lived very long periods of their life chronically depressed, so not really experiencing feelings of happiness or contentment and low motivation, are now having dramatic improvements in their daily functioning because they're able to feel some aspects of joy, and yeah, the effects can be quite dramatic in a positive way. So now I'm going to talk to you about electroconvulsive therapy, or ECT. So it's typically used to treat severe clinical depression, and you may know it from the media and various stereotypes or well-known ideas of ECT, which can actually probably be misconstrued about modern day ECT. So What it involves passing a carefully controlled electrical current through the brain, which then affects the brain's activity and aims to relieve severe depression and psychotic symptoms. So it induces a seizure that lasts for approximately 20 seconds, but can last as long as 3 minutes. And the effects can be quite dramatic. So 80 to 85% of patients who receive it will successfully reduce or recover from depressive symptoms. And most patients will remain well for many months afterwards. So it's a really effective form of treatment for severe depression. However, people can experience memory impairment or memory loss. However, ECIMH is currently exploring a new form of ECT known as FEAST, which may overcome these limitations. So it may help with the symptoms of depression without causing severe memory impairment. And that brings us to the end of the presentation. So I would love to hear any questions that you may have about brain stimulation, and I hope you really enjoyed the content. And hopefully it's inspired you about what's possible outside of university once you graduate. If you are interested in neuropsychology, I highly recommend it. So thank you very much.
Thank you very much, Freya. That was a fantastic presentation. I think we can all agree. I've definitely got a few questions here from students to go through with you. So I guess I'll just start off. So first up, Janice asks, are there side effects to these brain stimulation treatments? She hasn't specified which one.
Yes, so there's a range of side effects. Some are very mild and some are also very rare. So for instance, with TACS, there are very mild side effects like the tingling or itching sensation, or you could experience a headache or a neck ache, depending, but this is also very low and it will respond to medication like Panadol. So they're not very serious side effects. However, with TMS, there is a rare side effect of seizure, which is exactly why we don't apply brain stimulation to people with a history of epilepsy or seizures, because they already have those pathways in the brain that could be stimulated. However, the experience of a seizure in response to brain stimulation has never occurred in Australia, at least within the last 10 years, because there are so many safety guidelines around how we use it. We better understand how it impacts the brain, which is why we don't apply it to people who have a history of epilepsy. So there are side effects, but generally speaking, it's very, very safe.
Fantastic. Thanks, Freya. So we'll move on to our next question now. So Ollie asks, for the deep brain stimulation video, it said day in, day out. So I think we're asking, how many days does one have DBS for? And I imagine it's very specific regarding the condition. So for example, if manic depression was the condition, how many sessions or days would one require?
So DBS is actually a form of treatment that is ongoing. So people typically have, once they have DBS implanted, it works 24/7, 365 days a year. And typically people get batteries replaced every 10 years. So it's a lifelong investment and it works round the clock to stimulate parts of the brain that may be underactive. So it is definitely a treatment that people don't access unless they are resistant to other forms of treatments prior. But yes, it can really dramatically improve somebody's quality of life.
So we've got another couple of follow-up DBS questions here from Rachel. Thanks, Rachel. So she asks, is the surgery for DBS quite intensive? Is the device removable or does it remain in the brain? And then she has some follow-up questions also.
So Oscar may want to take this question. I'm not exactly sure.
Oh, Oscar.
Yeah, so that's a really good question. So obviously the surgery is quite invasive. The biggest risk of DBS is essentially the surgery, because any open brain surgery has associated risks. It's considered invasive because obviously there is a surgery, you're awake during the surgery, which regardless of how well traveled you are, is a strange experience to be awake during brain surgery. The device is removable. So if for whatever reason you didn't need it before, if we came up with another cure, or if it was well managed, you can remove it. You also keep in mind, sometimes they implant the device and it's maybe not as effective as they think it is, so it has to have the potential to be moved. So it can be, but the way these are typically done is that it is secure and non-invasive. So, you may not need, you could just turn it off if you didn't want to have it anymore rather than remove it. It might actually be less risky just to leave it in there. But you typically leave it in the brain and it remains on the whole time. So, they have some people who got the very early model of DBS stimulator, then got an upgrade, years later for one that was perhaps smaller or had a higher output, or the batteries needed to be changed less often. So these things are definitely removable.
So following on from that, Rachel has also asked, what are the ethics behind the delivery of deep brain stimulation? And I imagine the potential of malfunction could be quite scary, she also says.
Yeah, so I guess with any type of treatment, you have to weigh up the benefits versus the potential adverse outcomes. And with DBS, there has been enough research to show that the brain surgery can be done safely. And for a lot of these people, their quality of life is extremely low. So their version of life and their experience of life, they're willing to take the risks that come with brain surgery to have this device of the electrodes implanted in the brain and the device inserted into their chest to hopefully improve their quality of life. So ethically speaking, the benefits can outweigh the cons or the adverse effects that could potentially happen, and that person is well informed of all of those things before they take that step. And the process of actually getting DBS done is so long and extensive. They do multiple evaluations of your mental health, your physical health. There's so many different appointments that you have to attend, and it's actually a legal application process. So there's court proceedings to determine whether it is going to be beneficial or appropriate. So there definitely are strict regulations surrounding it. Even though it is still considered experimental, the benefits are there.
Thanks, Freya.
So can I add one thing to that with just the part about the machine malfunction? The way these devices are designed is that if for whatever reason there is a malfunction, the malfunction is in the direction of the machine stopping working, not, delivering too much stimulation or something like that. So they've got so many safety settings in there. So you're not going to suddenly have heaps of stimulation when you don't need it. It's got these sort of security settings that it just stops working. And the real, risk is not necessarily the machine itself. As we're saying, it's any sort of brain surgery. So that's the real one. There's a lot of safety steps between when creating these devices.
Awesome, thanks, Oscar. So I've got another question here from Rachel. She's asked, are there any other contraindications for brain stimulation other than epilepsy or seizures?
Yeah, definitely. So for instance, somebody may have had a surgery a long time ago where they had say an aneurysm. They had an aneurysm in the brain and they had to have surgical clips inserted into the brain to pin various parts of the tissue to improve that condition. And they may have had types of metal inserted that wasn't titanium. So titanium is non-reactive to magnetics. So if we're applying TMS, titanium is safe. But if somebody has had other forms of metal inserted into their brain for various reasons, it would be considered too dangerous to apply TMS because we could dislodge or harm the person in response to the magnetic response. So the same goes with MRI. So if somebody, for whatever reason, cannot have an MRI because they have metal somewhere in the brain or head, then that would also be a reason why they can't receive TMS, or it would be unethical to do that. So that's a potential reason, as well as, depending on the study, a substance abuse or dependence as well. But I think that's more to do with, you know, conducting good quality research to ensure that if you're measuring the effects of a treatment on a type of brain process, if somebody is abusing substances or is dependent on substances, the chemistry within their brain is probably being impacted by that. And so it's hard to ascertain as whether the treatment is working. So there's a range of things that we take into consideration through clinical interviews with people when they want to enter a study or receive stimulation. So all those things are kind of covered. I'm just wondering whether I know there's other things potentially. Oscar, is there anything that I haven't mentioned?
No, you covered pretty much all the main ones.
Yeah.
The only other one I would mention is if you are doing a stimulation for depression, if someone has a history of mania, so bipolar with manic episodes where people get, you know, elevated mood and very excitable and can make risky behaviors, there is a risk that it could trigger a manic episode in those individuals. One way to consider this is essentially an overcorrection. If someone's depressed and you're trying to improve their mood, it can improve above and beyond, and then you can trigger a manic episode. Now, this isn't necessarily a reason why you wouldn't have TMS, because it's a relatively low risk of mania and it's still effective for the depression, but it's something you would keep in mind if you were delivering it clinically. If someone had a history of mania or manic depression, you would monitor them a bit more closely than someone without that.
Awesome. Thanks, Freya and Oscar. We've got another question here from Tim. I think he's asking more broadly, but correct me if I'm wrong, Tim. He's asking, do you test the brain stimulation on yourself to get a first-hand understanding of the experience?
Definitely. Not the surgery, though. We usually try and avoid that one.
Yeah, definitely. I've experienced all forms of brain stimulation within ECIMH, I think, apart from obviously, yeah, ECT and DBS. I've experienced TMS, TACS, TDCS, even sometimes, you know, when you have to double check how the devices are going, wearing the headset yourself and assessing the stimulation, and being a part of some of the other studies we've done to assess the efficacy of the devices. We kind of act as guinea pigs for each other, and yeah, so you have a good experience as the participant as well as the person who's applying the stimulation. And it helps to also have that experience so you can explain it to people when they come into a study. This is what it's going to feel like. This is what might happen. You just have a better understanding, so you can communicate it better to participants.
Yeah, absolutely. And particularly if you're learning how to determine a resting motor threshold, you need someone else to do it on. So like you were saying, I think within reason, if you're asking someone else to do it, it's helpful to have done it yourself, to know what to experience and to understand what the participant and the individuals are experiencing as well.
Thanks, Oscar and Freya. So I've got another question here from Rachel. She asks, what kinds of settings is ECT used most often for severe depression? Is that mostly inpatient psychiatric units?
Oscar?
Yeah, so I can take that one. So ECT is delivered at most psychiatric units would have ECT. So in Melbourne, the Alfred Hospital, the Epworth. ECT is primarily used as a treatment for severe depression that doesn't respond to other treatments. As Freya really described very well during the presentation as well, the delivery of ECT has changed dramatically since it was first introduced. I mean, the big thing is having someone under a general anesthetic while receiving it. You don't want to be awake while experiencing seizures, and with a general anesthetic, the muscles are also relaxed. So it's there's not that much to see when it's actually being delivered. And yeah, so it's primarily used, it would typically be an inpatient setting, but even nowadays it's a day procedure. So people come in, like they drive in, they receive ECT, and you monitor them for half an hour afterwards, and then they go home. And it's a very safe and easy procedure. So I was surprised when I was learning about this, because I had heard the terrible things and One Flew Over the Cuckoo's Nest and all those bad portrayals. But the thing is, it's just really effective, and it's worth considering. Sometimes people talk about the ethics of it. No one is being coerced into this. These are people who have suffered with depression for a very long time. Risk of suicide is very high and acute in many times. People who aren't functioning, can't go to work, and they see really dramatic improvements. So many people really swear by it, and really glad that it's an option available to them.
Thanks, Oscar. We've got our final question here, unless any other students feel free to jump in with more questions. But another one from Rachel. She asks, how much training do you have to undergo before you start administering brain stimulation techniques as a researcher?
So personally, during my 4th year, I didn't apply brain stimulation. I only witnessed it and applied all the other different bits and bobs with EEG, EMG and that. But once I started working at MAPRC and then still here at ECIMH, I was trained by an experienced research fellow, a senior research fellow, who showed me how to apply stimulation. Colleagues helped and were, willing participants to receive brain stimulation from me. And you sort of have that ongoing practice and then ongoing supervision in the session to make sure everything goes well. And then over time, the training wheels kind of come off, and then you just start applying stimulation more increasingly and more broadly without any supervision. So I guess it's like anything, like driving a car, or you demonstrate that you can do it. You do it in a safe and controlled manner, and then the training wheels come off, and you can show that you can do it by yourself. So I think overall, that process probably happened over a couple months, and having understanding how to apply brain stimulation, you really need an understanding of the brain and stimulation first, so to begin with. So I don't think I would have learnt and adapted as quickly as I did unless I did my thesis around brain stimulation and really understanding how it works, because it's not the sort of topic that you just pick up so super easily. Like, you need time to understand resting motor threshold, TMS, how magnetic pulses or electricity can impact the brain. So yeah, that was a long-winded way of answering the question, but yeah.
Thanks, Freya. So
one thing, I would add to that as well.
Sorry.
Sorry to interrupt. One thing I'd add to that is it also varies a lot based on what technique you're using. So TMS it's really a skill to use, particularly if you're trying to find the resting motor threshold. I did so many during my thesis that I'd see someone and be like, yeah, I reckon I could find your motor threshold pretty. I'm like, there it is, it's right there. So trying to identify and how to hold the coil and everything like that. But for something like TACS, you could realistically get trained in a day. I mean, because we give these machines to people to deliver themselves at home, and they get like a single training session, because it's figure out where to attach it and press play, and if we've already programmed the machines and we know what settings to deliver, those sort of things, you could get trained very quickly. You could have your orientation week, and the next week you're doing these machines because it's programmed in there, and it's sort of all the settings, it's really clear to follow through. But like Freya was saying, some of the more technical things with the magnetic pulse and, holding it and everything like that, that can take a little bit of muscle memory and training.
Yeah, definitely. And yeah, I think that is, I guess, where the future of brain stimulation is kind of taking us at ECIMH, at least, is we're wanting to develop these at-home treatments that are easy to use, and they're kind of foolproof. Like the device has everything it needs already programmed inside. So with those sorts of things, it kind of cuts out needing to come into a clinic each day to receive handheld stimulation by a clinician or somebody who's trained with how to use it. So yeah, but definitely with TMS, you need training, and yeah, it's muscle memory. You might take a really long time to get that muscle memory, and it might be really difficult at first, but then once you've sort of got it, you can kind of find someone's resting motor threshold and get that twitch in the hand within, 1 to 2 pulses sometimes. It's happened to me before, and I'm like, wow, I'm really good. But that took a really long time to get to that level.
Can also confirm that the TMS coil is so heavy and trying to keep it in the right place at the right position can be quite challenging, but yeah, you do get there over time.
And I should say, you'd be surprised how light the actual magnetic part is, but it's because it needs to be cooled because it's sending so many pulses. It's got this like gel that's pumped through it to keep it all cool. So, you're standing there with it and your arm's getting sore, and you're trying not to push the person's head with the coil while you're using it. And yeah, it's a bit of muscle. It's a bit of muscle movement and muscle strength.
I think part of being good at TMS is you need to go to the gym and prepare your arm muscles.
Yeah. For sure.
Stand at home just holding a weight in one hand for an hour a day.
Yeah.
Thanks, guys. So I've got a final question from Tim. He's asking, how common is TMS for bipolar, depression, etc.? And are most regular psychiatrists informed of it, and do they offer it as a treatment?
Yeah, I can take this one if you want, Freya.
Yeah, I think so.
So I would say every psychiatrist has heard of it, or they're not doing their job, at least. I think last year in Australia alone, there was something like 200,000 TMS treatments performed. So it's quite common. And I think it's becoming more and more common as we're saying, it's now it's going to be added to Medicare, which means it's suddenly become a lot more common because it's a few reasons that Freya highlighted. Partially that a lot of people just don't respond to medication. And even if people do respond to medication, a lot of people just don't adhere to the medication because of the side effects. Weight gain, lack of energy, sexual dysfunction, appetite changes, all these sort of things. Some people are like, the benefits don't necessarily outweigh the side effects. And so TMS just doesn't really have those side effects because it's just targeting the one brain region. Some people, there might be a headache, particularly in the beginning. Some people actually do feel a bit fatigued, and that's because your brain's trying to sort of rewire itself. But I think the main limiting factor at the moment is not that people aren't aware of it, it's access to it. So a TMS machine isn't cheap. And up until now, well, still currently, as it's going through, you can't get it on public healthcare. So you need to have private healthcare insurance and somewhere where it can be offered. In rural areas, I doubt the local psychiatrist has the $200,000 TMS machine. But somewhere like, the Epworth in the psychiatry clinic, we have 3 TMS machines that run from sun up till sundown all day, delivering non-stop treatments. So it's becoming more and more common, particularly for depression, because before TMS came along, it was you have medication, of which 30% of people don't respond. And the next step is electroconvulsive therapy, which is a big jump between I took this pill and it didn't work and I'm going to the hospital, getting unconscious and having seizures induced. So it's this sort of middle ground that is effective for lots of people. And if it isn't, they can still go on to ECT. But as the technology develops, it becomes cheaper, becomes more widely available. I think we're going to see that this is going to become far, far more common. 10 years ago, you would never have even heard of TMS. It wasn't covered in most undergrad courses. Now they do often mention it at least, and definitely all psychiatrists should know about it for sure.
Definitely. And if it is available at your university, highly recommend. I think it just gives you a completely different insight into what's available as a treatment outside of, cognitive therapy by psychologists. There are like actual medical treatments as well that could help alongside medication and therapy, cognitive therapy.
Thanks, Oscar and Freya. So I've got another question here from Ollie. He's asking, do you need to be a psychiatrist to be able to deliver a TMS machine clinically?
So I'm not a psychiatrist and I deliver TMS. But then again, if it's in a treatment situation, a nurse or a clinician will administer it. So I myself, in a research capacity, collecting data for a study, I apply brain stimulation to amplify brain activity so we can get a better recording when we're targeting certain brain regions. But yes, treatment 5 days a week for 4 weeks. It will be conducted by a nurse, and it's a bit more, it's done by clinicians.
Thanks, Freya. So Tim here has another question for Oscar. He says, thanks, Oscar. How long until people can have their own mini TMS machine at a guess?
Oh, that's a tough one. I think there's two factors that are of importance there. One is...
I'm sorry, he said in a treatment setting.
Oh, in a treatment setting.
Yeah.
Yeah, I think the two factors there are probably cost, which at the moment is a bit prohibitive for most people. I think it's going to be a while away. There's also some technical issues with the power supply that's required for these machines because it uses a lot of power and needs to have a special plug. You know, it's got these big sort of amplifiers that generate the electricity to do the magnetic pulse. So I think we're a while away. The other thing is just at the moment, we want a psychologist can deliver TMS and a nurse can, a doctor can. But because TMS, there is a very small but significant risk of seizure, there's all these sort of safety things around having someone else there to monitor. So, you know, there's probably a chance, I think we may get to a point at some point in the future where we have a traveling TMS car, we can drive up to someone's house and someone can deliver it and monitor you while you get it. But I think having your own TMS machine is probably, you know, maybe in America where the regulations are pretty relaxed, but I think we're probably a while away from it. Someone did invent a tiny TMS machine that can do a single large pulse, which people say is good for migraine. When you feel a migraine coming on, you put it at the back of your head and a single pulse shoots into the back of your head. So that exists, but you know, it requires like 6 hours of charging for one pulse. And in your average theta burst, you deliver a couple thousand pulses. So we're not quite there yet, but hopefully TACS can bridge this gap, because I mean, you can build your own TACS machine with a single trip to Bunnings Warehouse and about $200. It might not be the safest sort of one. No, it's terrible. There have been thousands of people who have done it, and I think if it does improve your cognition, the first clear, intelligent thought you have was don't put homemade electronic devices on your brain. But I think we're on track to maybe having a bit more portable treatment machines, which I think will be helpful for a lot of people, particularly during this sort of quarantine lockdown. The fact that we have these machines we can give to people is great, because, you know, there's a lot of people with a lot of severe conditions who can't really leave the home, or definitely don't want to be visiting a hospital during a pandemic. So I think it's really promoting these sort of at-home things. I think it's probably spurred on a lot of innovation in that area.
Thanks, Oscar. Well, that was our final question. So thank you everyone today. Thank you for those that joined us, and thank you Freya for her fantastic presentation, and Freya and Oscar as well for answering all the student questions. Yeah, we hope you guys enjoyed it, and come along next time.
Bye everyone.
See you later.
Yeah.